Hello everyone. I'm going to talk on optimizing the outcomes in oocyte cryopreservation. So before I start my presentation, I would like to thank the organizers for the opportunity. This is the outline of my presentation. Before I discuss about the optimization of the cryopreservation process, I would like to take you through the biology of oocyte cryopreservation and the impact of cryopreservation on oocytes, and also about the key factors responsible for the oocyte cryopreservation outcome. The cryopreservation made a great revolution in the field of assisted reproductive technology. Specifically, the oocyte cryopreservation. One of the important indications for oocyte cryopreservation is fertility preservation. If you look at the number of cycles which are used for fertility preservation, have gone up significantly in the last 10 years. That means this oocyte cryopreservation has gained a lot of popularity these days. But when you look at the clinical outcome, the live birth rate between the fresh and the cryopreserved donor oocyte, there is a consistently, the pregnancies from frozen oocytes are lower compared to the fresh oocytes. And this could be attributed to the process of cryopreservation. So it's also important to understand the cryobiology of a cell before we go further. As we all know, the water is an important content in any cell, including the oocytes and embryos. When you bring down the oocytes or embryos to sub-zero temperature, the water inside the cell becomes ice. And this ice crystal can significantly affect the oocyte or a cell by causing dehydration, increase in intracellular salt level. This can eventually affect the protein and enzymatic activity. The organelle and cytoskeletal damage can even happen, which eventually lead to death of a cell. So this impact can be prevented by using certain chemical molecules known as cryoprotectants. These cryoprotectants are nothing but the agents which protect the cell from freeze-thaw induced injury. So there are different types of these molecules or the cryoprotectants. The penetrating kind of cryoprotectants are the small molecules. They can penetrate the oocyte or the embryos. They can pass through the membrane. And what happens? They displace the intracellular water. For example, these are the commonly used cryoprotectant like DMSO, the glycerol, ethylene glycol. They are used either singly or in combination. There are certain large molecules, because of the large size, they cannot pass through the cross membrane, they cannot cross the membrane. But what they do, they create a hypertonic exterior and protect the cell. These are basically the sugar molecules, could be sucrose, trehalose, or lipoprotein. So these molecules, the cryoprotectants, help in preventing the cryo injury caused by the cryopreservation. What actually happens, this is a schematic representation of actually what happens during cryopreservation. When you expose a cell here, the oocyte, to a cryoprotect or the cryoprotective solution, immediately there is the penetrating cryoprotectants can cryoprotective agents will enter the cell and water molecule comes out of the cell and non-penetrating cryoprotectants, they attach to the membrane and prevent the cryo injury. So when there is no water inside, no ice crystal formation, and there is a minimum cell injury. The whole process is reversed during warming. So during warming, when we keep them in a thawing solution or a warming solution, the water in the warming solution will get inside the oocyte or a cell, and cryoprotectants come out of the cell. So this eventually lead to cell rehydration, reorganization of the cytoskeleton, and cells attain the metabolic functionality, physical functionalities come back, and eventually they become normal. From the oocyte perspective, here we are discussing mainly about the oocyte. So from the oocyte perspective, it's very important to know how oocytes are different from the embryos and other cells. As we all know, oocytes have a lot of water. Their chromatin architecture is different from the early embryos. Their ability to sustain cryo injury is also different because of the size and the open meiotic spindle and many changes in the cellular organelle. So because of this reason, the oocytes are more vulnerable to cryo injury compared to the early stage embryos. Now let's look at how we can perform cryopreservation. There are two methods, the slow freezing and vitrification. The slow freezing is the oldest technique where the cells are brought down from the ambient temperature to minus 196 with a very low cooling rate. Whereas vitrification is nothing but the rapid, ultra rapid freezing from the ambient to minus 196. The cells are trapped at a very high cooling rate. We can attain up to minus 25,000 to 35,000 degrees centigrade per minute. By doing that, there is a formation of a glass-like state. As you see here in this picture, when the cryoprotectants are kept, the cryoprotectant is ethylene glycol and DMSO. When it is brought down to sub-zero temperature, it forms a glass-like structure, unlike DPBS, where you can see ice crystal. So because of high concentration of the cryoprotectant, viscous solution, and even rapid rate of cooling will protect the oocytes and from the deleterious effect of cryopreservation. Now, the question is, how good is the vitrification? There are several studies comparing the benefits or the impact of vitrification and slow cooling, but I am showing only a couple of reports which show that the oocyte vitrification is much superior to slow freezing with respect to clinical pregnancy rate. And which a recent study, the meta-analysis, which has also shown that vitrification is superior to slow freezing. The vitrification has gained a lot of popularity because it doesn't require any machine, expensive machine, and it doesn't require more time. Embryologists need not have to spend more time for vitrification. And the oocyte vitrification is very successful. It is no more considered as experimental. As I told you earlier, it requires a few chemicals which have the good buffer, the cryoprotectants such as DMSO or ethylene glycol, and sugar molecules and antibiotics. So what actually happens during the vitrification is that the oocytes are exposed to equilibration solution to get out of the water molecules inside them. And then once the equilibration is attained completely, the oocytes are transferred to vitrification solution, droplets of vitrification solution, and finally they are loaded onto a cryo device known as carrier and then immersed directly inside the liquid nitrogen. We should also know that it's an important change happens during the process of vitrification, that is change in the osmolarity. For example, here, if you see here, the osmolality of oocyte is about 280 milliosmol, whereas the culture medium also has similar osmolality. But the equilibration solution is almost tenfold higher, which is very important for the water molecule to come out of the oocyte. Whereas vitrification solution, again, it is about 10 times higher than the equilibration solutions, about 5,600 milliosmol, which is very important for the cryoprotection. So these are the physiological, supraphysiological changes which happen during the process of vitrification. There is a temperature differential from incubator temperature of 37 degrees centigrade. The oocytes are brought down to room temperature and then immediately plunged to liquid nitrogen with a very high cooling rate. There is also an osmotic shock from 280 milliosmol to 5,600 milliosmol. So these changes, these supraphysiological changes may have significant impact on the oocyte, the structural and functional competence. There could be impact on oocyte maturation and viability. There could be effect deterioration of centrosome cohesion, could be a high risk of aneuploidy. There is to the cell cycle chromatin architecture, cytoskeleton, and eventually the survival and the functional competence of the oocytes may be compromised. This is because the oocyte is a very unique cell. As you see here in this, it's the largest cell in the body, has a lot of water in it, and effective dehydration is a challenging task in oocyte because earlier, almost if you look at about 20 years ago, the oocyte cryopreservation was almost impossible because of the meiotic spindle was open, a lot of water in it, and the large size, the slow freezing was not very successful. And there could be a possible impact on other cellular organelles. There could be impact on the membrane permeability, the cortical granule release, and zona hardening. So these can significantly compromise the functionality of the oocyte. In addition to this, during cryopreservation, here vitrification, the cryoprotectants which are used could be PROH or ethylene glycol. They have the ability to premature calcium rise inside the oocyte. When they get inside the oocyte, they may cause premature calcium rise, and then this can eventually affect the mitochondria and release of ROS. And increased ROS may compromise again the fertilization and embryo developmental potential. Studies have also shown that the meiotic spindle can be affected with the vitrification because in metaphase 2 mature oocyte, the meiotic spindle is open. And as you all know that the spindles are thermosensitive. They can get depolymerized with a low temperature. And here is the data which I came across recently, which shows that it's a non-frozen oocyte. The meiotic spindles are intact. And here the oocytes are vitrified 4 hours after collection. There is a deterioration, the distortion of the spindle. And when the oocytes are vitrified 8 hours after collection, there's a complete distortion of the meiotic spindle. So this is a little bit concerning. So this could lead to embryonic aneuploidy. But interestingly, the studies have shown that the long-term cryopreservation of the human oocytes does not increase the embryonic aneuploidy. Here is the data comparing between the fresh oocyte and the frozen thaw oocyte. Look at the euploidy, the implant ploidy status, the implantation rate, the clinical pregnancy, or the live birth rate are not significantly affected by oocyte cryopreservation. It's important to understand the key factors which are responsible for the vitrification outcome in oocyte. The primary factor is the patient, could be patient, the age of the patient, the pathology, the source of the gamete, it is from the patient or from the donor. In addition to this, the oocyte-related factors such as the maturity of the oocyte, whether they are in the GV stage, metaphase 1 or metaphase 2, the quality of the oocyte, whether they are fresh oocytes or in vitro matured oocytes. The process of vitrification, how effective is the equilibration, the vitrification, the medium, the technique used, the process of warming, and post-warming factors. All these factors can significantly affect the outcome of oocyte cryopreservation. It is shown that the oocytes from poor ovarian reserve have compromised survival. Their survival may be affected post-vitrification. So low serum AMH is considered, the serum AMH can be considered as a marker here to predict the oocyte vitrification outcome. It has been shown that low serum AMH is correlated with the low survival rate after oocyte vitrification. Even the blastocyst formation rate is also much lower in vitrified oocytes from the advanced age patient compared to the fresh oocytes. Here is another recent study which looked at the oocyte survival rate with respect to different age groups. But interestingly, this study did not show any significant difference with respect to survival rate. They have done it in about 3 groups in less than 36 years and 36 to 39 and more than 40 years. And therein the survival rate is comparable and there is not much of a difference with respect to the. On the other hand, I came across another interesting study which used a very high number of, large number of oocytes and looked at in 5 different age groups and which clearly shown that the oocytes from advanced age patient are compromised ability to progress beyond blastocyst stage and also to establish pregnancy. If you look at the ratio of total number of oocytes thought to total number of live birth is almost 3 times lower in patients who are below 35, whereas here the more than 42 years, it's about 122.4 oocytes. It says that the oocytes from advanced age patient have compromised ability to establish pregnancy. Now the question is when to perform cryopreservation oocyte vitrification, how long we can wait. Here is the data. We show the post-HCG less than 38 hours, 38 to 39 hours, and more than 39 hours of HCG. And they also compared the oocytes derived from IVM, but interestingly here, they didn't find any difference with respect to survival rate, though there is a marginal difference, but maybe because of the low sample size, they could not establish any significant difference. But it's important to know that the IVM oocytes are more vulnerable because they experience in vitro exposure and they are more vulnerable to cryopreservation thawing, which is again clearly shown here. This is a study which compared the vitrification warming of IVM oocytes and fresh oocyte. And as you see, a fresh IVM oocyte and vitrified IVM oocyte, you can see a significant difference with respect to clinical pregnancy and live birth. Here is the data which compared when to do vitrification. Suppose if we get GV oocyte, whether to vitrify them at GV stage or mature them and then do vitrification. There's the comparison between the two groups, vitrified at GV stage and vitrified at metaphase 2 stage post-IVM. And here the data shows that we can achieve better success by performing in vitro maturation, and then when they attain metaphase 2 stage, then you can vitrify them instead of freezing them at the GV stage, because we believe that GV stage chromatin is more intact and more stable, but the data shows that it is always better to do in vitro maturation and then vitrify, so you'll have better success. So, which is again, there is a meta-analysis which also looked at a comparison between the vitrification of human oocyte at GV stage, which shows that the GV stage vitrification can negatively affect maturation rate, and maturation rate reduction happens by 24%. So, GV stage vitrification is not recommended for human oocyte, and if there is a possibility, it is always better to mature them then perform vitrification, so you'll have a better outcome. So sometimes we also get a cohort of metaphase 1 oocytes along with metaphase 2 oocytes. So there's a study compared the outcome when cryopreservation vitrification was done with the metaphase 1 oocyte. And the study has shown that by vitrifying metaphase 1 oocyte, you can get a comparable survival rate. And there is not much of difference with respect to outcome. But the study has also shown that vitrification procedure, if the M1 oocytes are derived by in vitro maturation, then their meiotic competence is compromised when compared to freshly retrieved metaphase 1 oocytes. Now, I would like to briefly discuss about some of the technical factors which can affect the vitrification outcome, the type of carriers, whether they are open or closed carriers. There is not much of difference, which I'll be showing you later. The equilibration time and the temperature, the cooling and warming rate, and the storage phase. These are some of the important technical factors known to affect the vitrification outcome. There are several devices available in the market which are known as carriers. I don't have any conflict of interest. We can use any of these carriers which you think which are more comfortable. And some of them are open system and some are closed system. The closed system is recommended if you are concerned about the safety of the sample. If there is a risk of cross-contamination, then it's always better to go for closed system. The question is whether how are there a difference with respect to outcome. There are a couple of studies, the meta-analysis comparing the open versus the closed system vitrification system, and these studies have not shown any difference with respect to the clinical outcome when we use either open or closed system. Another important factor we should consider is equilibration time and temperature. As I told you earlier, equilibration is the most important step, which is very essential to eliminate the water molecule from the outside. And equilibration is normally attained at room temperature because the cryoprotectants are known to be toxic at high temperature. So ideally, it should be done at room temperature. And how long it should be done? The study comparing the equilibration time with less than 10 minutes and up to 15 minutes, and the study did not show any difference with respect to survival rate. But what is very important from the practical point of view is it's always important to assess the oocyte morphological changes under microscope during the process of equilibration. And once the oocyte attains the normal morphology, once it regains the morphology, then it is better to, then you must stop the equilibration and proceed with vitrification. Loading is another important factor. Ideally, loading should be done with less than 1 microliter of vitrification solution. This is the right way of loading because if the volume is large, then this can compromise the cooling rate. The cooling rate is affected and which can eventually affect the survival of the oocyte. And ideally, the vitrification medium, the time in vitrification medium is about 30 to 90 minutes. Again, because if you keep for a larger time, this may it may be toxic or it may negatively affect the survival. And number of oocytes, how many oocytes we can freeze in a carrier, that depends on the stage of the oocyte, the availability of the oocyte, the quality, and the requirements. So these days, there are some new gadgets known as the pod and garage system, basically to minimize the volume of cryoprotectant. So these gadgets have used a very low volume, maybe nanoliter. So it is believed that these devices can significantly improve the outcome, mainly because of the low volume, which helps in attaining a very high cooling rate. People have also looked at the use of slush nitrogen during for oocyte cryopreservation. And if you look at the results, they are comparable survival rate, the fertilization rate, and rate of usable blastocyst and aneuploidy rates are comparable by using slush nitrogen. So you can attain a comparable result even without using slush nitrogen for oocyte cryopreservation. So we are in the era of microfluidics. Microfluidics have come in various process in the ART lab, and there's also a possibility to use microfluidic platform for oocyte one-step vitrification. I don't have any personal hands-on experience with the microfluidics, but I hope this is the future of oocyte vitrification. So as so far we have discussed about the biology of the cryopreservation, vitrification, and what are the key factors responsible for vitrification outcome. So these are the four major points, important key points, which are responsible for the vitrification outcome: the efficient dehydration and rehydration, the effective cryoprotection, the high cooling and warming rate, and stable temperature at sub-zero. If all these four factors are considered carefully, then one can attain a very high very good outcome with the oocyte cryopreservation. This to summarize and to conclude my presentation, the oocyte vitrification is highly effective. It is no more considered as experimental from the embryologist and the clinical point of view. And the factors such as the maturity of the oocyte, the age of the oocyte, the quality needs to be considered prior to freezing. And it's always important to understand that we are exposing the oocytes to supraphysiological condition, maybe high temperature, increased osmolarity, so which could be detrimental. It may have a long-term impact. So since we don't have adequate safety data on oocyte vitrification, our approach should be very careful, and importantly, use of oocyte-specific protocol. We cannot generalize the protocol for cryopreservation. We have to optimize depending upon the stage of the oocyte, depending upon the apparent quality of the oocyte, and make sure that we have the right protocol for the right oocyte. With all these, we can attain very high success rate in our oocyte cryopreservation program. Thank you very much for your consideration.